Hey there, friends. Welcome to Mind Matters, Navigating Head Injuries and Concussions. My name is Kiley Como. I'm the in-house legal nurse consultant here at Shane Smith Law. Today, we're excited to have back with us Dr. Bashuk from the Concussion Center in Atlanta, Georgia. Dr. Bashuk, welcome back to the show.
Kiley, thank you for inviting me here today. I'd like to talk today about a whole new way to think about concussion as a nocioplastic disorder. This is a new term for a lot of people. I hope in understanding this new concept that it'll create a sense of urgency among medical professionals to start treatment for concussion as soon as possible. At the Concussion Center, we see all types of concussion, whether this is due to concussion from sports, from an assault, from a slip and fall, blunt force trauma, motor vehicle accidents, or bike accidents. We're located at 2200 Century Parkway near Claremont and 85. We take a multifaceted approach to concussion care, acute concussion, persistent post-concussion symptoms. We evaluate autonomic nervous system dysfunction, cervical dysfunction, ocular motor and vestibular function, dietary and nutritional aspects, sleep, and emotional aspects, all associated with concussion. So I want to start by thinking of concussion as a new paradigm, which is as a nocioplastic disorder. And this disorder was first described about 8 years ago by a professor named Dr. Joe Nijs, I think it's Nij, and he's from Belgium. And a lot of the information that I'm going to give today comes from two papers. There's a paper by a Dr. Qureshi. It's in PubMed number 383-38173. Again, that's 383-38173. It's called The Conservative Management of Acute Sports-Related Concussion, a Narrative Review. This was published in February of 2024. And then the other paper is by Dr. Volchek, and this paper is titled Central Sensitization, Chronic Pain, and Other Symptoms, Better Understanding and Better Management. And this is out of the Cleveland Clinic Journal of Medicine, Volume 90, Number 4, April of 2023. There will be references at the end. There are some other papers that are used, and that most everything should be, I've got references on most of the slides as well. So we're going to go ahead and get started. So concussion is a nocioplastic disorder due to central sensitization. So concussion is a nocioplastic disorder due to central sensitization. This is part one. So our objectives today to explain how concussion should be considered as part of a new pain disorder, describe the need for a sense of urgency in concussion management in hopes of preventing what's known as persistent post-concussion symptoms, also known as post-concussion syndrome, describe the similarities of concussion, migraine, and whiplash, and update the management of concussion and persistent post-concussion symptoms. So what I'd like to do is go through 8 definitions. So the first definition is going to be concussion, then persistent post-concussion symptoms, pain, nocioplastic disorder, cortical spreading depression, central sensitization, microglia, and something a lot of people may not have ever heard of is the glymphatic system. So let's go to the first definition for concussion. So this is the consensus statement on concussion in sport. This is from the 6th International Conference on Concussion in Sport in Amsterdam of 2022. Now, one of the things about concussion is there's a lot of work that's done in sport concussion. And one of the reasons sport concussion gets so much publicity is it's easier because, especially with professional sports, college sports, high school sports, when it's going to happen. And you also can get these people together and do baseline testing with them. You really can't do that in somebody if it's a motor vehicle accident or it's a slip and fall or if it's an assault. But with sports concussion, these people, when they're at risk, and you often have medical people on the sidelines or are easily available. So it makes it easier to do testing. But again, concussion is a concussion. Once you've seen one concussion, you've seen one concussion. But the definition for concussion is a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain. It's important. It can be from a direct blow to the head, neck, or body. This initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation affecting the brain, also known as neuroinflammation. We're going to talk a lot about neuroinflammation in a few minutes. Symptoms and signs may present immediately. They may evolve over minutes to hours, and they commonly resolve within days, but they may be prolonged. So a traumatic brain injury, there's a continuum, and concussion is considered to be a mild traumatic brain injury. There's also a moderate TBI or traumatic brain injury and a severe TBI or traumatic brain injury. But on the scale, a mild traumatic brain injury is also known as a concussion. So more talking about the definition of concussion. A concussion is a temporary energy deficit. It is due to acceleration, deceleration, which results in stretching and shearing of neurons. It is not coup contra coup. The function of the brain is altered, but not the structure. 70% of people are going to improve in about 2 to 4 weeks, but there's about 25 to 30% of people who will go on to develop persistent post-concussion symptoms, also known as post-concussion syndrome. And is there a way to increase that 70% and reduce that 30%? And we're going to talk about that in just a few minutes. So concussion, the neurometabolic cascade with concussion, basically there's sudden neuronal firing or neuronal depolarization. It's an excitation that occurs and it lasts for seconds to minutes. This is the electrical chaos that occurs after somebody hits their head. The brain does not like this, okay? It's kind of like a seizure. It just happens so suddenly. The brain and our body can deal with things when they're slow, but when things are sudden like this, the body just has a hard time dealing with it. So there's this sudden neuronal firing, a depolarization, the electrical chaos, and then this is followed by neuronal depression. And this depression will last for 3 to 6 weeks. And with this depression, this is the energy crisis that occurs. And this is when a person is most vulnerable to suffer more injury if they were to have a second concussion. With this cascade, you have collapse of the neuronal microstructure. There's shearing of axons. This leaks out of the neuron, causes inflammation in this area or neuroinflammation. It disrupts what's called the blood-brain barrier, and all of this is invisible. So with this neuronal depression, it's due to the influx of calcium that rushes into the mitochondria of the cell. Once this concussion occurs, this damages the mitochondria. There's a 20% drop in ATP production in the brain, and again, it takes 3 to 6 weeks for the mitochondria to heal. One thing that you need to know is symptoms may actually improve before the mitochondria have healed. So you really have to be careful about when you let somebody return to play. And this is a controversial issue. If it takes 3 to 6 weeks for the mitochondria to heal, then should that person return to play a sport that they're at risk for another concussion in a week, which is what a lot of the protocols will allow to happen. And so you think about it like a fracture. If you had a fracture, it's going to hurt really bad, but in a few days that pain's going to go away, but it hasn't healed. It's going to take a couple of months to heal, and you can't go back and do your activities until the fracture is healed. And I say the same thing about the brain. The brain needs to heal before you go back to play. So some myths about concussion. I just think these are really important. I know we talked about this the last time we spoke, but I think it's clearly worth repeating because this is such an issue people get misinformed about. That you have to, first of all, the first myth is you have to be knocked out to have a concussion. Absolutely not. 90% of people do not get knocked out that have a concussion. If you hit your head today but don't have symptoms until tomorrow, it's not a concussion. That's absolutely not correct. Symptoms may occur immediately. It may occur minutes, hours, can occur a few days later. you have to hit your head to have a concussion. Absolutely not. It's your head, neck, or body. You always see stars when you have a concussion. No, that is not correct. When you do see stars, it is consistent with a concussion, but that actually happens a small percentage of the time. Concussion is not an actual brain injury. Of course, it's an actual brain injury. We just discussed that it's a mild traumatic brain injury. There are blood tests and brain imaging tools that can diagnose a concussion. Well, there's no brain imaging tools at this time that it can diagnose a concussion, and there's actually no blood tests that can diagnose a concussion. However, there are blood tests that are available, but there are problems with the blood test. They have to be done within like 24 to 48 hours, and they're actually approved to determine whether this person should have a CAT scan of the head or not necessarily for a diagnosis of concussion. Myth number 7 is a big one. There's no treatment for concussion. There's treatment for all aspects of concussion. And the biggest myth of all, and the number one myth, and if you don't remember anything about this lecture today, this is the biggest myth: rest until symptoms resolve. That is the biggest mistake ever. People need to start exercising within 2 to 3 days after the concussion. And the treatment of concussion is what's known as subsymptom threshold aerobic exercise, also known as the Buffalo Concussion Treadmill Test or the Buffalo Concussion Bike Test. So definition number 2, we've already alluded to this a little bit: persistent post-concussion symptoms, also known as post-concussion syndrome. This is where the symptoms of concussion last for more than 4 weeks. And what we want to do is we want to try to start treatment for this concussion before this person develops persistent post-concussion symptoms, because they can last for months, even years, and it can cause a lot of disability and a lot of heartache. So number 3, third definition: pain. Now I realize that everybody knows what pain is, but there is an actual definition of it, and the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated or resembling that associated with actual or potential tissue damage. Very important that you understand actual or potential tissue damage, because I'm going to change this a little bit when we talk about nocioplastic pain. Let's do number 4, nocioplastic. So you need to know that there are 3 pain phenotypes. There's nociceptive, neuropathic, and nocioplastic. Nocioplastic is the new one. It was, again, we first started learning about this about 6 or 8 years ago. But nociceptive pain, everybody knows what nociceptive pain is. This is when you put your hand on something hot and you pull your hand away. That heat stimulates the nociceptors, the little nerve endings in your hand. It sends a signal through the arm into the spinal cord to the brain, and then the brain sends a signal back to your arm to move your arm away. This is when you step on a nail, step on a piece of glass, when you get pinched. That's nociceptive pain. Everybody understands that. Then neuropathic pain is also, most people are aware of this. This is shingles. When you get shingles, it affects the nerve. Diabetic neuropathy. If you have a pinched nerve in your neck, you have a pinched nerve in your back, there's an actual injury to the nerve, and you feel that in the part of the body where that nerve is. But then there's a third type of pain called nocioplastic. So nocioplastic pain is pain that arises from altered nociception, despite no clear evidence of actual or threatened tissue damage, causing the activation of these nociceptors, these peripheral nociceptors in your hand, your feet, your leg, your arm, and there's no evidence for disease, and there's no evidence for a lesion of the somatosensory system causing the pain. So nocioplastic pain, there's no tissue damage. There's no lesion of the nerve that is causing this pain. So the relevance of this term lies in the recognition that not all chronic pain conditions can be explained solely by structural or tissue damage. So again, this is just a little graph showing what we just talked about. Nociceptive pain, you'll see where it says, what is it? The first question there on the left. So nociceptive pain, there is actual or the threat of tissue damage, neuropathic pain in the middle, there's a lesion or disease of the somatosensory nervous system. But nocioplastic pain, there's altered nocioception. And again, if you go to the second, where it says pain localization under nocioceptive pain, it's localized. It's where you put your finger on that burner. The neuropathic pain, that shingles, it's along a nerve, maybe it's in your face, maybe it's along the chest. But nocioplastic pain, it's not in a neuroanatomical distribution. Definition number 5, cortical spreading depression. And we've already kind of talked about that when we talked about concussion. We talked about the excitation that occurs followed by depression. And this depression lasts for 3 to 6 weeks. So cortical spreading depression, this is a wave of neuronal firing or depolarization followed by depression of cortical activity. And this pathophysiologic process can be seen with migraine with aura, stroke, and traumatic brain injury, especially concussion. Central sensitization, and we're going to spend a lot of time on central sensitization and nocioplastic pain. What is central sensitization? This is defined as an amplification of neural signaling within the central nervous system that causes pain hypersensitivity. It increases the amount of pain even when there may not be a painful stimulus there. So a lot of patients with chronic pain lack a clear origin of nocioceptive input, or the input doesn't suffice to explain the pain, the disability, or other symptoms. In these patients, central sensitization can explain the chronic pain experience. So this idea of central sensitization the guy who came up with this idea was a guy named Wolf, and this was back in the 1980s, and this is his definition. So central sensitization is where the central nervous system changes, distorts, or amplifies pain. It increases the degree of pain, the duration of pain, and the spatial extent of the pain in a manner that no longer directly reflects the specific qualities of the peripheral noxious stimuli, but now it's a functional state of the circuits in the central nervous system. So it doesn't mean that the pain is not real, just that it's not activated necessarily by noxious stimuli. Think about the person who has back pain and he's got a disc and it's pinching on a nerve, and he goes in, he has surgery, the disc is removed, the nerve is not being irritated anymore, but he still has pain. This person had pain for such an extent that this acute pain, this peripheral pain, peripheral sensitization, transformed into central sensitization. So the brain learned to change the pain. And that's what we're going to talk about.
I did have a question. With something like you see this more frequently now, fibromyalgia kind of on the scene, it's been around for a bit, but now we're starting to see more complex regional pain syndrome patients. Does that fall into that category of nocioplastic disorder?
So the answer to that is you're jumping ahead, which is perfectly okay. You're perfectly okay. All right.
Leave it to me.
That is a great question, actually.
We can get to it later.
I'm going to address that specific issue, actually, more in part 2. But the answer to your question is absolutely yes. I think fibromyalgia, complex regional pain syndrome, I think these are all nocioplastic disorders. And if you think about it, fibromyalgia, they just hurt all over. Well, why? Well, I think that is due to central sensitization that results in a nocioplastic disorder. So that's a great question, and we're definitely going to address that, and good thought on your part. So central sensitization is now a well-established feature in a lot of patients with chronic pain, including those with low back pain, neck pain, headache, post-cancer pain, fibromyalgia, osteoarthritis, pelvic pain, post-surgical pain, and some pediatric pain. Microglia, definition number 7. So you've got 4 different types of glial cells, and these are cells in the brain. Okay, there's neurons and there are glial cells. So all the glial cells have a different function, but we're going to talk just about microglia today because I think they are just absolutely fascinating. But they are the immune cells of the brain. So you get something in the brain that shouldn't be there, the microglia become activated and they try to take it out. So with microglial activation, we know it plays a big role in concussion, persistent post-concussion symptoms, migraine, whiplash, and other nocioplastic disorders like fibromyalgia, complex regional pain syndrome. So microglia tend to be quiet, but once they get activated, they are deeply involved with neuroinflammation. They pick up, they see neuroinflammation has occurred. Remember I told you, I said early on with the concussion, you get shearing of the axons. Well, that causes leakages of things that should not be leaked out. The brain does not like that. That causes neuroinflammation. The microglia, they come in and they try to fix it, and they release reactive oxygen species. They release what are known as these proteins called pro-inflammatory cytokines, and they try to get rid of this pathogen, these toxic proteins that occur. And once that pathogen or the reason for the neuroinflammation has been destroyed, then the microglia need to be quiet. They need to go back to their resting state, but sometimes they don't. And if they remain activated, they cause persistent neuroinflammation. And when you have neuroinflammation and microglia are activated, this causes symptoms of headaches, memory dysfunction, brain fog, irritability, insomnia, photophobia, which is light sensitivity, phonophobia, which is sound sensitivity, glymphatic system. So what is the glymphatic system? When there is the prolonged presence of neuroinflammation after a concussion, this may be associated with dysfunction of the glymphatic system during the acute phase of the injury. So the glymphatic system was not discovered until about 10 years ago, and it is the waste clearance pathway in the central nervous system, and it plays a crucial role in removing metabolic byproducts and cellular debris after a concussion. Think about your kidneys, okay? Kylie, if I said, I'm not going to let you go to the bathroom today, you're going to have to wait 18 hours, you're going to be dying over there, okay? You're going to struggle. You're not going to be able to think. You're not going to be able to focus. You're going to be irritable. Well, that's what happens with the glymphatic system. So with a concussion, 60% of the glymphatic system, it doesn't work. It's not as efficient. And so if the glymphatic system is not working properly, well, then you get buildup of waste products in the brain. And that causes neuroinflammation and headaches and dizziness and memory issues, anxiety, irritability. And 80% of the glymphatic system clearance occurs during sleep. So you get a concussion and you're not sleeping, your glymphatic system is not working. That's why these people are having so many of their symptoms, because neuroinflammation persists, the microglia remain activated, and it's just a vicious cycle. Think about the glymphatic system like this. Again, if I ask somebody to stay up for 36 straight hours, I mean, you could do it, okay? If you had to. But I promise you, those last 12 hours, you're going to be really tired and really irritable, and you're going to have brain fog, and you're going to struggle to be able to focus and get things done. And that's because your glymphatic system, you haven't gotten rid of these waste products. So now you sleep for 12 hours, and how do you feel the next day? You feel awesome. If you didn't urinate for 18 hours and then you got to urinate, I mean, you're going to feel awesome after that. So the glymphatic system is a big part of this. So this is a term I actually came up with, okay? I was thinking one day, I was seeing somebody and I said, I know what this guy's got. He's got post-traumatic status migrainosis. And this is the guy that comes into the office. I'm sure they come into y'all's office. They come into my office, they come into the primary care's office, and the story is, I had a concussion 3 weeks ago, and I've had a headache all day, every day since then. We know what status migrainosis is. That's for somebody with migraines. Post-traumatic headaches, we know what that is. But when you go on 2-3 weeks with a headache all day, every day, I think that term actually should be called post-traumatic status migrainosis. I've never seen it in the literature, and I've looked it up a couple of times, and I haven't found it. Just this is my thought, okay? Whiplash, well, we know what that is. Railway spine. It first was described in the 1800s in England, associated with the railways. And we know that is with neck pain, and that can lead to chronic neck pain. So I think all of these disorders have a lot in common, okay? Concussion, whiplash, migraine, post-traumatic headaches, post-traumatic status migrainosis. The symptoms are essentially identical. They're the same symptoms, actually, when you don't get to sleep at night, okay? You get the same symptoms. So here are the symptoms, and we know all this. Headache, neck pain, light sound sensitivity, memory complaints, brain fog, insomnia, anxiety, irritability, fatigue, difficulty concentrating, exercise intolerance, numbness and tingling or paresthesias, and dizziness. These all occur with migraine, concussion. They occur with whiplash. They occur with lack of sleep, PTSD, long COVID. All of these have very similar symptoms. So what is the mechanism? How do we go from an acute problem to acute pain to chronic pain? How does it all occur? Well, this enhanced response is in part due to neuroplasticity. Everybody thinks neuroplasticity is good. And neuroplasticity is good. Neuroplasticity allows us to learn, allows us to memorize things, to learn how to hit a baseball, to be able to study and understand things. And this is the ability of the central nervous system to adapt over time. But sometimes neuroplasticity is not beneficial. And when you go from central sensitization to nocioplastic pain, that is not a good thing. So acute pain is adaptive. It's protective, and it occurs when there's a harmful stimulus, activates a peripheral nerve. This goes to the spinal cord, to the brain. It alerts the organism to this threat, and it helps the organism to escape from danger and recover. That makes really good sense. But we know the process is actually a lot more complicated than that. So this peripheral nerve, which is activated, receives this stimulus. The message is reviewed neurochemically. Some of the neurochemicals increase the message, others decrease the message, and this inhibition and amplification occur in the brain. And then the brain sends messages back down through dedicated neural pathways. And this is usually a very well-balanced system. So if you perceive something harmful, you get away. But if it's something that's not threatening, then it's minimized and it may not even come to the level of conscious awareness. So central sensitization, in this pathophysiological state, the central nervous system becomes hyperexcited, even in the absence of a sensory stimulus. And the sensory messages are amplified, and it can be internal or external to the body. So there is the trifecta of central sensitization. So one, hyperalgesia. So what is that? So that is a painful stimulus that is a lot more painful than you would expect. So you have a lesion, and maybe there's some redness there, and you touch it, you push on it, and the person just jumps. It's so painful, okay? I mean, normally, maybe that stimulus that you gave them is uncomfortable, but they shouldn't be jumping out of their shirt for it. That's hyperalgesia. Allodynia. So allodynia is something that is not painful, is now painful. Think about a sunburn, okay? So sunburn, you get in the shower every day, you put the water on, the water's warm, doesn't ever bother you, but now that you've got the sunburn, it hurts because it's a non-painful stimulus, which now causes pain. About 3 months ago, I had COVID. I didn't know I had COVID, but my first symptom was I had allodynia, and it wasn't bad. I wasn't in any severe pain, but I could just feel the sheets of the bed or the clothes. It wasn't terrible, but I said, boy, this just, something's not right. And, I had a couple of other symptoms, and, I did a COVID test and it was positive, and it lasted for about 3 or 4 days and went away. So allodynia. And then global sensory hyperresponsiveness. Now, this is very interesting. And this is, these patients are extremely affected by external and internal stimuli. And I bet you y'all have seen them in your office. I know I see them in my office. Mm-hmm. So these people are really, really sensitive to bright lights. And this is the person who is in my office. I had a couple just the other day. They're sitting in the dark and they're wearing sunglasses because any type of light, just opening the door bothers them. Loud noises just drive them crazy. Their smells, foods, medication, they're just super sensitive. So these people, they have central sensitization, and this leads to the nosoplastic disorder. So acute concussion can become persistent post-concussion symptoms or post-concussion syndrome. Episodic migraine can become chronic migraine. Whiplash becomes chronic neck pain. Why? Question is, why does that happen? So is central sensitization the cause of chronic migraines? Is central sensitization the cause of persistent post-concussion symptoms? Is central sensitization the cause of chronic neck pain? Is central sensitization the cause of failed back syndrome, fibromyalgia, TMJ? Are these nosoplastic disorders? Is it due to prolonged activation of microglia, neuroinflammation, and lymphatic dysfunction?
All right, Dr. Bashuk, thank you so much for that in-depth discussion on concussions and their management. I think that we're going to wrap up this part of our discussion right here. So for our listeners, that means if you're going to need to join us again for part 2 of the discussion here with Dr. Bashuk from the Concussion Center to hear more. So that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. We hope that you found this discussion not only informative but interesting. So please be on the lookout for future episodes as we continue to dive into the fascinating world of head injury and the amazing work being done to understand and navigate these issues. Please remember to hit that like button, and if you're not already, subscribe to our channel to keep up with our latest and greatest content. And as always, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.